Now we are going to ask Dr. B.C. Srinivas, who heads Jayadeva Institute of Cardiology, and he's a very busy interventional cardiologist, specializes in recanalizations of central veins apart from many endovascular procedures and coronary procedures. So he is going to be talking about tips and tricks for recanalization of central vein occlusion. Dr. B.C. Srinivas.
Good afternoon, Dr. Khanna. Good afternoon, the panelists, Dr. Michel Henry, Dr. Tyagi, and Dr. Rao, Dr. Ashokan, and all the delegates. At the outset, I would like to thank the Asia Pacific Society for providing this opportunity, Dr. Khanna especially. I'll go to my first slide. As you can see, central venous occlusions, present in a very moribund state. CKD is a morbid disease. For the purpose of dialysis, they create AV fistula to have high flow rates to dialyze the patients. When they develop central venous occlusions in the presence of a AV fistula, you have a moribund state like this. You can see these pictures. Some of them do ulcerate, and then recanalizing them is very difficult. But I would like to take you through the tips and tricks of these central venous recanalizations. I do image them with ultrasound Doppler and sometimes even CT venogram to understand the occlusions, the proximal site of occlusion, the distal anatomy of occlusion, and what exactly is happening in the occlusion. As you can see here, the length of occlusion, the diameters proximal and distal to the occlusion, you can study well. So this is a simple innominate vein stenosis. You can see. This is a focal stenosis, which we cross with a Terumo wire, and most often I snare them out from the right femoral vein. I have a veno-venous loop on, one from the upper limb, and then snare it out from the right femoral vein, and do my, intervention from the right femoral vein. And most often I use the non-compliant Atlas balloon, as you can see. The Atlas balloon, actually, the reason why I use the Atlas balloon is it doesn't duct bone even at very high pressures, and these lesions can be well expanded. Once you do it, you get a great result like this. Most often these are maintained. Some of them do come back with restenosis. Let us see this. In fact, this was way back in 2009. I did this case, actually, one of the first cases. What I generally do is to assess the anatomy of these lesions. Okay, to assess the anatomy, I come from the right femoral vein, look at the innominate vein ostium. In this case, it is occluded. Beyond this, we cannot, enter through this lesion. Most of the time, it will be difficult to engage and get into this lesion. So what I do is I get into the axillary vein. As you can see here, there's axillary vein, and then introduce a sheath and try to understand by giving an injection, look at the anatomy. So in this particular case, as you can see, the anatomy favors to go anterogradially from the right axillary vein. So that's how we understand and then start the procedure. Here I have a Cook curved catheter, which actually nicely curves into the lesion, taking that, if you take the anatomy into consideration, it is sitting nicely into the occlusion. And then you maneuver your wire and then cross this lesion. Many a times it will be very tough, but you have to persevere, and with patience you have to do this. Once you cross, then you snare it out from the right common femoral vein. So you have established a veno-venous loop between the right axillary and the right femoral vein. That helps you to push through your hardwares. Now, once you have done that, then you can introduce the balloon and then balloon dilate. Once the most often long occlusions, I generally long occlusions of this kind, I strain them. If it is a focal lesion, I generally don't strain them. I just send them with a balloon dilatation, and you do have a great result like this. In fact, this is post-stent implantation. Similar, you can see here, left innominate vein is normal, right innominate is occluded, and you can see that the right innominate, the characters of this particular lesion, it is favorable to come anterogradely from the axillary vein. So I puncture the axillary vein, either fluoro-guided or ultrasound-guided, and then get a sheath in, come close to the lesion. So if you are close to the lesion and coaxial, most often, the crossing is easier. Once you cross the same steps, you just, either you daughter the lesion with the sheath and then take a smaller balloon, create a passage, and then use the atlas to adequately dilate it. If it is a long segment, generally, a long segment of this kind, I stent them. Otherwise, I try for balloon alone. See this. This is a very morbid case. Just look at the amount of edema. It's chronic central venous occlusion in the setting of CKD. You can see that where I have gone. I have gone into very close to the into the axillary vein here, and it's one of the longest occlusions. Actually, you can see the right denominator is occluded, and in fact, from the axillary it starts at subclavian and into the innominate all the way to the SVC. It is occluded. These are very difficult to treat. Many a times, in this case, I tried hard. The wire actually, after coming from the subclavian innominate, actually I could not get into the true lumen. It went into the wall of SVC. You can see here. So in this case, what we try to do is to come from the femoral vein side, use the broken bone needle, and then try to get into the track which we are coming from above. Here also I couldn't get through, so I allowed the patient to recover, and 6 weeks later I reattempted. In this time, if you once I engaged in the once I engaged into the occlusion, what I did was to try to get the loop of the wire within the occlusion. When you get the loop of the wire and then transmit your catheter force, generally it goes, you can see here the wire loops and then knuckles, and once it knuckles, it passes through the lumen. This I have seen happening many times in chronic long segment venous occlusion. So once that is done, then you can, the rest of the steps are the same. You establish a venous loop, and then, dilate them adequately, and then put in, this particular case, this actually both 1 year and now 4-year follow-up, she is doing well, actually. This is another case, similar scenario, long segment, left innominate vein occlusion. From here, you can see there are transcervical collaterals which are decompressing to the SVC. So from SVC, almost entire length of the left innominate till the subclavian is occluded. Understanding the anatomy is extremely important. See here, we initially thought that this is the the actual innominate vein. That was not to be, actually, because whatever we tried, we couldn't cross this lesion. Again, I just 3 weeks later I reattempted. Went very close to the lesion. You can see that I'm injecting close to the lesion. And initially we had thought this was the track, but that was not the track. And if you see carefully, that line, that is actually the innominate vein. So after understanding that, next steps, you take a good support catheter and try with a wire, and you can actually, I could go through the entire innominate vein and then cross it. Once crossed, then you capture that and then snare it out, and then establish a venous loop, predilate a longer balloon, and then of course you stent them. So and you get a good this is a very it was a very challenging case. This was almost 18 years history of SVC syndrome, which was referred. You can see that the SVC was occluded, right subclavian innominate was occluded, left subclavian was occluded, left innominate and from the subclavian it was occluded. So here we started our case because the anatomy was favorable from the right subclavian, but ended up with the wall of the SVC there. So what we did, so we did not have a choice. We came from right femoral vein. You can see that you look at the wire loops in the occlusion. When it loops in the occlusion, you have a support. This is a very good support. The sheath is giving good support. You can push through. And that we captured from the left subclavian and then exteriorized that. And then created the left limb. So one limb that is from the left innominate into the SVC, recanalized. Once we recanalized that, then we reattempted the right one. For the right one, what I did, I left that wire from above, which was going into the wall of SVC there itself, and then used the broken row needle in different angles. In this particular case, choosing the angle was important. The LEVO view actually helped me to identify the exact origin as that ostium of that innominate vein. Once that was there, then we could use the brook and broad to connect those two. The wire coming from above and from below through the right broken from right femoral vein, reconnected that, and then ultimately established flow. Once we established both limbs, then after pre-dilatation, you can see that the flow was established. Then we could use two self-expanding wall stents and then create the innominate vein into the SBC. So if you understand the anatomy well, you can use sharp recanalization techniques actually judiciously to recanalize them. And in fact, the results are very gratifying because the edema resolves rapidly, headache decrease, vision better. This is almost 10 years follow-up now. That particular case. Sometimes you have IVC obstruction, and this was again central right innominate vein obstruction. So to reach the right innominate vein, I had to recanalize the IVC with serial balloon dilatations. Once that done, then I had to I tried from the antegrade approach again. I could not recanalize from above. Then I had to resort to the broken broad technique. Ultimately, initial in fact there was the puncture of the vein, but that we compressed from outside and sealed it, and then again reconnected from the right innominate into the subclavian. And once we reconnected, then pre-dilate them well, because it's a long occlusion. The same balloon I used for the IVC, and then this is a long stent which with a good decompression of the entire right upper venous hypertension. So if you understand the anatomy, you can judiciously use the sharp recanalization technique, either using the broken broad needle or the back end of the wires, and then shape them adequately to give adequate shape according to the vein shape and the vein occlusion length, etc. So this was again a bilateral innominate vein occlusion giving rise to SVC syndrome. You can see that the SVC syndrome resolves so rapidly, but you should be careful. They needed additional ventilation for about 7 days, because it was going for recurrent pulmonary edema, because the shift of fluid from the third space into the circulation, that you have to be very careful. Again, another SVC syndrome, you can see that the SVC was occluded. And here, it is not necessary that you reconstruct both the innominate veins into SVC. Even one innominate vein, if you can recollect. For example, in this case, we have recanalized from left innominate vein into the SVC. You see how clinically they respond very well. So even at least one limb of innominate vein into SVC, you can recanalize. The SVC syndrome resolves rapidly. Just to give another complication, I don't use the semi-complaint. In this particular case, my associates were using this semi-complaint they used, and suddenly they noted that there was a rupture of the vein, and they called me immediately. So what we did was we actually put in a wall stent to see whether that helps to clear the layers. But that did not help. What we did on the shelf, we created using a tie shack 20 into 40 millimeter balloon, and cut the balloon adequately like that, and took out that balloon material, which is cylindrical balloon material, that, and then created a on site. Actually, we created mounted it on a bare metal stand and used a Vicron absorbable suture on either end to tie that balloon cylinder on the bare metal and then deployed across that. So it was actually because we did not have a adequate sized covered stent, so we created a covered stent and closed it off. You can see here that we sealed that rupture, and then you can see post procedure the left upper limb venous hypertension resolved rapidly. So when you do this kind of procedure, stent restenosis is an issue. You have to redilate them, so you have to be prepared. You have to tell these patients also that you have to, the re-intervention is a norm in here. Many a times they do come back at 3 to 6 months interval with restenosis, and then you may have to redilate them. Here the idea is to have a good flow rate through the fistula, so that they can dialyze the patient well. With that in mind, you have to be prepared for re-intervention. So these are re-interventions done at various parts of the time. Actually, we have done about close to 311 patients now. Central venous occlusions contributes to morbidity in CKD. Those who are on maintenance hemodialysis, when they develop central vein occlusion, it becomes very difficult to dialyze them, and it's also, can lead to upper limb venous hypertension induced morbidity. Imaging, of course, is extremely important to understand number one, to diagnose, and of course, to plan your procedure. Pre-procedurally, you can plan your procedure. Of course, endovascular approach with PT and stent implantation is safe. It is effective in central venous occlusion, no doubt about it. But you have to be aware of the sharp recanalization techniques, especially in long segment total occlusions, to increase your success rates. And of course, one has to be well versed with antegrade approach, retrograde approach. And of course, your access when you are doing intervention has to be coaxial to the occlusion, so that the chance of crossing is very high. You should know how to establish venous loop, so that facilitates and improves the success rate of recanalization. And of course, the need for repeat intervention, you should be aware. PTA does help in maintaining the flow rates in the vein to facilitate dialysis in this moribund group of patients. Thank you once again, Dr. Khanna and team, for giving me an opportunity to share this.
Thank you very much, Dr. Srinivas. It was truly wonderful. Everybody acknowledges your expertise in not only in venous recanalization, but also in other endovascular techniques. And I totally agree. I mean, I do a lot of these almost every week. We do many cases. We are the biggest, transplant center for renal transplant center in the world for last 5 years. And we have huge number of these cases actually coming in. And what is the most important, I mean, I agree with your suggestion, is to have the access as close as possible. So on the subclavian or axillary or innominate, and one should have both access, groin as well as the upper arm access or the neck access, and also have a very good veno-venal loop and have a coaxial way to actually puncture it blindly. Many times we use stiff thermowires, hard end of the stiff thermowire, and sometimes even broken burrow needles. And what also I see sometimes, very rarely, when the wires won't go, sometimes a good slippery coronary wire can slip into a small channel, and then we dilate with a coronary balloon and then can pass in 035 wire. So thank you very much, all the speakers. I would especially want to thank Dr. Michel Henry and Dr. Srinivas, Dr. Rahul Jindal, and Dr. Sokan, and also Dr. Ra to have come. And thank you all very much. And now I'd invite Dr. Ra for the next session.